In India, the DIPSI criteria is followed. Okay, DIPSI criteria is also a one-step procedure in which, whenever the female comes for an antenatal visit, irrespective of the previous meals, give her 75 gram of glucose, and then after 2 hours, check out the blood sugar. If the blood sugar is more than 120, the female is having glucose intolerance. If the blood sugar is more than equal to 140, it is gestational diabetes mellitus, and if it is more than equal to 200, then it is said to have a overt diabetes. So this is a DIPSI criteria which is done in all pregnant females in India, as in India the Asian population is a high risk population, so it should be done. And there is no fasting needed, so it is a preferred criteria in the females. So DIPSI should be followed. And now the one-step approach and two-step approach. In the one-step approach, I've already tell you that this is a DIPSI, and it is a simplifies diagnostic testing by performing a 75 gram. Just note down the amount of glucose to be taken by female. In the one-step approach, it is 75 grams. In the two-step approach, in the first step of which is a screening method, 50 gram of glucose, and it is a glucose challenge test. In the second step, the patient is asked to take 100 gram of glucose, and it is a 3-hour oral glucose tolerance test, which is a diagnostic test for a gestational diabetes. And the diagnostic criteria of with 75 gram of glucose, the fasting should be 92, 1 hour less than 180, and 2 hour, sorry, more than 180, and 2 hours should be more than 153. And if it is more than this, the female is said to have diabetes, and that she is a diabetic one. Now the management of diabetes in pregnancy, the first and foremost, the diet modification should be carried out, and exercise should be there. Asked the female to do some exercises. Okay, so the diet modification and exercise is ask the female to do this thing for just 2 weeks. And our aim for metabolic goals should be like target fasting blood sugar in between 70 to 95. Our target for 1 hour postprandial is less than 140. For 2 hours should be less than 120, and HbA1c 1c should be less than 6.5 percentage. Okay, if the target is not attained, okay, by 2 weeks, then what? Then the drug of choice for treating the female is insulin. Insulin during pregnancy, the dose of insulin is generally increased during pregnancy, while during labor, the dose of insulin is decreased. It is decreased because the female during labor is on liquid diet or nil oral. Okay, so as she is not taking anything, thus the dose of insulin is decreased in the females. And oral hypoglycemic agents are contraindicated during pregnancy, as it can cross the placenta and can cause fetal hypoglycemia. Okay, and the next thing, the complications of diabetes in pregnancy. The first one, for maternal complication, there are increased chances of infections which can lead to asymptomatic bacteriuria, and the female is prone for UTI, urinary tract infections, which can also lead to preterm labor. Preterm labor can arise because of this, and premature rupture of membrane can also happen because of this. Now, the polyhydramnios is because as the mother is having hypoglycemia, and this glucose is transported in the fetus, and the fetus is now hypoglycemic, and here the fetus is releasing so much of urine which will lead to polyuria, and this polyuria is causing polyhydramnios, which can cause further more complications like premature rupture of membrane, preterm labor, malpresentation or preterm labor, or APH, abruptio placenta, or maybe cord prolapse, or PPH. Now, the big placenta and maternal distress, as the big placenta can cause placenta previa or PIH, pregnancy induced hypertension, and the maternal distress is because of the respiratory discomfort the mother is facing because of such a big size uterus. uh, and diabetes mellitus chances increases in the future. In the upcoming 20 years, the female is sure she can get diabetes, and thereafter delivery between 4 to 12 weeks, the female is advised to go for GTT, glucose tolerance test again. Okay, now the fetal complications. First of all, gestational diabetes is associated with a number of maternal complications like preeclampsia, polyhydramnios, prolonged labor, PROM, preterm labor also, obstructed labor, cesarean section, uterine atony leading to PPH, and infections, UTIs. So these can be maternal complication. Now the next thing, fetal complications. So the fetal complication, fetal hyperglycemia, which can lead to increase insulin. Already discussed, insulin can lead to increasing the growth of fetus, which is a macrosomia. When the size of weight of macrosomia, when the size of fetus weight of fetus increase by more than 4 kg. Actually, in India, the criteria of macrosomia is more than equal to 4 kg, while there in the world it is more than 4.5 kgs. In increase in weight of fetus more than 5 kgs. And also increase insulin can lead to decrease surfactant, which can lead to respiratory distress syndrome. Now the macrosomia. Macrosomia is a fetal complication. Okay, and when the fetus is male, he is more prone to have a macrosomia. Also, it can occur in the post-stated pregnancy and in the diabetes mother, obviously, and the male fetus. So these three things make the baby more prone for macrosomia. Now the USG parameter to diagnose macrosomia is abdominal circumference. When the abdominal circumference is more than equal to 35 centimeter, okay, and it is known as macrosomia. And the organ which is least affected in macrosomia is brain is least affected in macrosomia. And how to manage the patient when the baby is macrosomic? So we should go for cesarean section, not never go for vaginal delivery in that females. Go for cesarean section. This is a macrosomic baby. You can see the baby is so much plumpy, so much weight. Okay, so this is so fatty baby looking very cute, but this is a very dangerous condition. So macrosomia. During vaginal, macrosomia can lead to shoulder dystocia. So the vaginal is generally avoided and the female is asked to go for cesarean delivery. We'll discuss this macrosomia, shoulder dystocia, and death of fetus, that is intrauterine death of the fetus, more in other upcoming lecture. Stay tuned for that. Okay, now going to neonatal complications. Neonatal complication is prematurity or RDS hyperviscosity syndrome, which is polycythemia plus hyperbilirubinemia, which is a hyperviscosity syndrome. So viscosity syndrome is polycythemia plus hyperbilirubinemia, prematurity, hypoglycemia less than 40 mg per dl of glucose, and decreased calcium, magnesium, and potassium, which is having more complication. Because of this, the baby will have more complications. But anemia and mental retardation is not seen in the babies of diabetic mother. Best test to assess the lung maturity is phosphatidylglycerol. Okay, it's phosphatidylglycerol, which is the best test to detect the lung maturity. And if present in phosphatidylglycerol is present in the amniotic fluid, then the lungs are mature, and if it is not present, absent, then the lungs are not mature. This is all about neonatal complications. Thank you. Stay tuned for more upcoming videos. We'll discuss macrosomia, shoulder dystocia, and intrauterine death in upcoming videos. Thank you.